I want everybody who agrees with the motion, here it is, all children should be switched to dolutegravir-based ART regimens, to raise your green cards. And those of you who are against the motion, put your red cards up. And we'll start with the pro, which is Addy.
Thank you, Di. Good morning, everyone. I could tell right from the beginning, from the morning, that all of you wanted dolutegravir for children. Okay, I have no disclosures. So what do we know about dolutegravir? We know that dolutegravir is an unboosted integrase inhibitor. It has a rapid and durable virological response. It has a high genetic barrier to resistance. It has low toxicity. It has a low pill burden once daily. It has few drug-to-drug interactions. And it can be given with TB, which is a challenge for our children. And we know that it already has a fixed dose formulation. And this is why we need it for the children. We know that the 2016 guidelines already have promoted it as a first line for adults because it protects against treatment discontinuation from adverse drug reactions. But we also know that the same guidelines in June 2017 showed that it was approved for children 6 years and above, and because it allows for harmonization for drugs. It allows for families to have less issues when they are giving drugs. But more importantly, we know that it can prevent the spread of HIV drug resistance to improve viral suppression and quality of life for children living with HIV/AIDS. Some of you may not know that children living with HIV/AIDS have a challenge with viral suppression. Just to look at Helen's presentation at CROI, close to 65.5% of the children had less than 50 copies. Look at this, the fears that were done. Almost all countries showed that children have a high problem, with close to 53% of them having resistance to NNRTI, a good substitution, as you can see. This is even worse in Malawi. For those of you who are coming from Malawi, you can see the fear there showed that 0 to 4-year-olds, only 19.3 were suppressed. But why do we see this low suppression? We see this low suppression because the children are on suboptimal or poorly tolerated regimens. And this has been shown, this report is available in the PADO 3 report. And we also know that the currently available regimens by WHO for children above 3, you have abacavir 3 TCF Adherence, it's not a fixed dose formulation. We have abacavir 3 TC lopinavir, it's not a fixed dose formulation. And those are the challenges that we are trying to solve. And how can we solve it? With dolutegravir, which has very good efficacy and safety. We have reviewed the systematic, we had Helen Cantor's review the systematic review of close to 34,000 clients who were studied, and they showed that viral suppression at 96 weeks was much better compared to efavirenz, nevirapine, lopinavir, ritonavir, and even discontinuation due to adverse events was much better for efavirenz. It is superior in efficacy even as a second ART in experienced children. The sailing study has shown us that. The spring 2 has shown us that. And what does that mean? That even for children, we could easily switch them without necessarily waiting to do viral load, because viral load is a barrier for switching. We know that even for third line, the sailing study has shown us that with viral failure, even when you just add 2 drug classes, you are still doing very well. The same with the Viking study. Now, some of you may be wondering, but it is only for children over 6 years. No, we are working very hard. Impact 1093, Odesse are working very hard to identify doses below for children less than 6. Lou and colleagues showed that for children 6 to 12 years, there was good efficacy and safety. And we also have PK results between 2 and 6 years. It has a low pill burden, as you all know, and it can be taken twice daily for those that are on TB. We know that it can form, we have children-friendly formulations, 5, 10, 25, but just look, the crosses there. On the extreme right, we have liquid formulation. Look at that face. The child is resisting. Look at the next one. Those are pellets, and they just stick in the mouth. And is that what we want for our children? We can have better formulations. We know that PK issues for DTG are excellent because children in Africa cannot take without food. They claim food is a barrier, but here there would be no food barrier. Let's also talk about other pertinent issues, ladies and gentlemen. How many of us have seen children pregnant? I'm sure none of you has a child pregnant in their homes. But we also know that data on long-term efficacy and safety is ready in about 2 years with the Odessa trial. And before you leave, Odessa and Impact may share with you some very interesting data that will influence WHO. We also know that research on PK with the dispersible tablets, which are even better, is about to come out. So in summary, why should we all now change our mind? It is a good option of what we call ART optimization. It's potent. It's low toxicity. It's well tolerated and easy to take and administer. It has a high genetic barrier. It improves sequencing and switching options, and can be harmonized across different countries and across different age populations. And overall, WHO has negotiated costs, reduced costs or negotiated. Thank you for listening. Let's debate.